what is your practice, Mirvat, in these patients for the vast majority?
The vast majority, I would stage, to be honest, I won't do it in the index procedure. I think, it gives you time to kind of reassess the patient as a whole, their clinical status, in terms of fluid status and so on, get an echocardiogram and have a conversation with the patient about what comes next in terms of dual antiplatelet therapy and risk modification and so on.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to episode 99 of Parallax. This is an episode which is being recorded just at the conclusion of a very important annual cardiovascular meeting or scientific sessions for the cardiology community. The European Society of Cardiology Congress is an extremely well-attended Congress, happens about this time each year, and some incredible science is presented across the spectrum of all subspecialties within cardiology, whether it's cardiovascular imaging, advanced heart failure, cardiac electrophysiology, or interventional cardiology. And for the 99th episode, which is being recorded at the helm of our centennial episode, episode 100, with Professor Valentin Fuster, I'm extremely delighted and honored to have amongst us Dr. Mirvat Alasnag, and that name needs no introduction. Whether it's cardiology or interventional cardiology, she's an international superstar as an interventional cardiologist in Saudi Arabia, cardiac catheterization laboratory director at her institution, and is among the Board of Trustees at Society for Cardiovascular Angiography and Interventions, and is part of the American College of Cardiology's Interventional Leadership Council. So, incredible roles, and just an incredible role model for, all of us within the interventional cardiology community. I've told her, off the record, that she's omnipresent, which is a great compliment, because she's at the meetings and, in cases, and, she does such a phenomenal job in explaining and presenting the latest science and data. So with that introduction, Mirvat, welcome on the show, and thank you so much for doing this for us at such a short notice.
Ankur, thank you for having me in this wonderful introduction. You really do humble me, and congratulations on your podcasts. They're just very consumable, and we all listen to them to refresh our memories of trials and so on, and to dissect what's coming up. So yeah, thank you for doing this for our community as well.
Oh no, thank you. The pleasure is all mine. I get to spend some quality time with guests like yourself. So Mirvat, getting into the meat of the topic, which is an ESC 2023 wrap up, and I specifically wanted to request your participation for this episode, because this ESC, particularly in comparison with some of the previous ESCs, I've felt, maybe I'm biased, but I felt that was presented some great science from our perspective, the perspective of an interventional cardiologist. And so we'll just jump right in and begin with you taking us through some of the important trials you felt were practice informing or practice changing for our community.
Absolutely. Thank you. So there were some very impactful trials that were presented, specifically in two areas. One was complete revascularization, and the other one was in the space of intracoronary imaging. And I do think they will eventually change the guidelines. So if we go ahead and start with the trials that covered revascularization, complete revascularization, there were two trials. One was the FIRE trial, and one was the Multi-Stars AMI. The FIRE trial, what's interesting about it is it really enrolled patients over the age of 75 who are often underrepresented in clinical trials, including and specifically in the setting of STEMIs and acute coronary syndrome. So this actually showed us that not only can we be doing PCIs in the elderly population, but we can also conduct trials safely in them. The FIRE trial really looked at patients who were over the age of 75, who had an ST elevation MI or a non-ST elevation MI, and had successful percutaneous revascularization of the culprit lesion in the setting of multivessel disease, where there was at least another non-culprit coronary artery involved. So these patients were then, after the successful revascularization of the culprit, randomized into complete revascularization that is physiology-guided or PCI of the culprit-only vessel. So the patients in the culprit-only revascularization group did not undergo any physiologic assessment at all, and the primary outcome was a composite of death, MI, stroke, and ischemia-driven coronary revascularization within 1 year of randomization. And then the secondary outcome was a 1 year composite of cardiovascular death and MI and the individual components of that. They ended up enrolling over 1,445 patients from 34 sites. The median age was actually 80 years, and women were about 36.5%. The primary outcome occurred in 15.7% of those who had physiology-guided complete revascularization and 21% of the culprit only. NNT was about 19 in this population. So with the exception of stroke, each component of the primary outcome was lower in the physiology-guided complete revascularization, including death. So I think the only takeaway message is complete revascularization is important. Physiology-guided revascularization is useful. We can do it in the elderly. Probably my only additional take-home from this is that, we don't look at age as a number. These were, when you look at the demographics of the population involved, they were actually robust patients. And so other factors that impact outcome in this population besides age is, of course, comorbidities and frailty, which is not directly related to age. The other trial is the Multi-Stars AMI trial, which really looked at immediate complete revascularization at the time of the primary PCI, compared with a more staged procedure. So patients were actually randomized on a one-to-one basis to immediate or staged within 19 to 45 days of successful PCI of the culprit vessel. And the primary endpoint was all-cause death, non-fatal MI, stroke, and unplanned ischemia-driven revascularization or hospitalization for heart failure after 1 year of randomization. They ended up enrolling about 840 patients from 37 different sites in Europe. And the primary endpoint in the immediate revascularization was 8.5%, and it was 16.3% in the staged group. So it met the non-inferiority. It was a non-inferiority design, and it met the non-inferiority component of that. In terms of non-fatal myocardial infarctions, it occurred in 2% of the immediate group and 5.3% of the stage group, with a 64% relative risk reduction. And likewise, when we look at ischemia-driven revascularization, it was 4.1 versus 9.3% with a 58% relative risk reduction. So really, the rate of all-cause death, stroke, and hospitalization for heart failure did not differ between the two groups. And the conclusion here is that immediate PCI is non-inferior to staged PCI in the setting of ST elevation, myocardial infarction, and multivessel disease. Perhaps the only other message that I would say here is there, again, other factors. It's a non-inferiority design, but other factors come into play in practice, meaning how far is this patient? What is their renal function? Will they tolerate more contrast load? How complex is the complete revascularization of the other vessels, and so on? Maybe even what time of day it is. So those were the two most important in terms of revascularization. And I think maybe we can, for the sake of time, dive into the trials that actually looked into intracoronary imaging. What do you think?
Yes, Mirvat, this is a really succinct summary of two really important trials which were presented at the meeting. I have to really congratulate the investigators for FIRE, right? One is to randomize a demographic, like you mentioned, in the age group that they did. A median age of 80 is excellent in the AMI population, in the acute myocardial infarction population. So, that has been a data-free zone for quite some time, and I'm glad that they could conduct a physiology-guided revascularization trial in that patient population. And it turns out that it was significant. I mean, number needed to treat of 19 is just is impressionable, to say the least. And also, I think congratulations are in order also because of the percentage of women in that demographic that were recruited. You said 36%. So, really good job. Just fantastic job, from the investigators there. And just to put this in perspective from a clinical practice point of view, both FIRE and multi-stars AMI, how do you treat these patients? I think at the end of the day, we try to garner as much information we can from these randomized clinical trials, and then sort of transmute that information to the patient, the individual patient at the bedside. And you did bring up individualization with regard to complexity of coronary anatomy, comorbidities, time of day, contrast use. What is your practice, Mirvat, in these patients for the vast majority?
The vast majority, I would state, to be honest, I won't do it in the index procedure. I think, it gives you time to kind of reassess the patient as a whole, their clinical status, in terms of fluid status and so on, get an echocardiogram and have a conversation with the patient about what comes next in terms of dual antiplatelet therapy and risk modification and so on. So that, generally speaking, that is what I would do. I would resort to immediate if the patient has difficult access, for example, and so on.
Yeah, and I know we aren't specifically talking about DAPT strategies, because we were just talking about complete revascularization. But when it comes to dual antiplatelet therapy strategies, duration of DAPT in these patients, now that we're talking about the elderly patient population, and the comorbidity not infrequently also includes atrial fibrillation. Is it your practice to stop the aspirin from the very beginning and just have them be on dual antithrombotic therapy? For example, a P2Y12 and a DOAC, or do you do triple therapy for at least a month and then transition them to dual antithrombotic therapy? That's one. And that was sort of like the second segment of the question. The first segment being, what typical duration are you comfortable with in these patients in the setting of an acute coronary syndrome?
The European guidelines would recommend for somebody with an ACS, the default is 1 year. But then we have to evaluate the patients longitudinally and see if they develop a bleeding risk or an ischemic risk and tailor the antiplatelet duration accordingly. So there's, a more abbreviated if they're high bleeding risk and a more extended if they're at high ischemic risk. And I've avoided now going with triple therapy. I do it while they're in hospital, sort of like with the Master DAPT trial and so on. And then I would send them home on a single antiplatelet with an antithrombotic therapy. And on that note, there's a trial that was presented at ESC called the Optic Biorisk trial, which was very interesting because it actually tapped into an area that we don't, which is specifically what you're talking about right now, that we don't really have many studies to guide us, which is a lot of the time the risk factors that render an individual high risk for ischemic events also render these same individuals at high bleeding risk. Age, for example, renders an individual high risk for both renal dysfunction and so on. So what they did is they took individuals, this was a Chinese randomized trial that took patients who were on dual antiplatelet therapy after successful complete revascularization and after being event-free for at least 6 months. Then they randomized them to single antiplatelet with a P2Y12 inhibitor, clopidogrel, or dual antiplatelet therapy. They had a run-in period of aspirin for approximately 3 months just to make sure there's no fall-off. And then they actually saw that the patients who had monotherapy had lower bleeding risk, which was the primary endpoint, PARC 2, 3, and 5. But they also had lower ischemic events, major adverse cardiovascular and cerebrovascular events, which was the secondary endpoint. Now, this was very interesting that the monotherapy, they had lower ischemic events as well. And, the investigators, when they were questioned, they said that maybe some of the remedial measures and medications that the patients were given when they had bleeding events on dual antiplatelet rendered them higher risk of ischemic events. So at least that was an interesting trial I thought I'd just plug in.
Yeah, no, extremely relevant. Thanks for bringing it up. I think what has slowly happened in my practice, at least, is in patients with chronic coronary syndrome, which is stable coronary disease patients beyond 6 months of dual antiplatelet therapy, at least in a non-ACS setting, a non-acute coronary syndrome setting. I've become very comfortable in just continuing clopidogrel monotherapy and actually stopping aspirin, because the more we learn and the more data we're garnering around aspirin, it just feels that there are more bleeding events compared with lack of benefit when it comes to ischemic events. So just a great addition to our discussion there, and thanks to our expertise for bringing that up for our audience, which I think is a great segue for us to now talk about all the imaging trials and the imaging data that were presented. Also a meta-analysis which was published, in a very timely fashion, sort of accruing all these individual patient level data together. So why don't you talk to us about the imaging trials?
We all want, have been advocating use of imaging, and we want more uptake of imaging in order to optimize our PCIs and get cabbage-like results. So the one trial that we were looking out for was the Illumian-4, and this caused quite a ripple at the Congress. So the Illumian-4 comes off the Illumian-3 trial, which really looked at angiography-guided PCI versus OCT-guided PCI, and they note that OCT guidance improved procedural success. There was better stent expansion, less malapposition, and major dissections. But we don't know if that translates into clinical events, and that's what Illumian-4 was designed to answer. It was a 1-to-1 randomization. They took high-risk patients, and they defined high risk as not just the anatomy of the lesion, CTO, long lesions, calcified bifurcations, etc., but also the patient, if they were diabetic, on treatment, and so on. So they took these patients who were high risk, and they randomized them to OCT guidance alone or angiography alone PCI. And the primary endpoint, it was powered for imaging with minimum stent area assessed by OCT, and they looked at a superiority design there. And primary clinical endpoint, again, it was powered to answer that question. They looked at target vessel failure, defined as cardiac death, target vessel MI, and ischemia-driven target vessel revascularization. Superiority design again. The safety endpoint was stent thrombosis, but it wasn't powered for that. Ultimately, they ended up enrolling 2,487 patients, randomized into 1,200 plus in the OCT arm and 1,200 plus in the angio arm, and followed them up for 2 years. Now, the primary imaging endpoint was achieved where the minimum stent area was bigger in the OCT guided, 5.72 compared with 5.36. The primary clinical endpoint, which it was powered for, was not met. So target vessel failure was 7.4% in the OCT arm, and angio was 8.2%. P-value was only 0.45. So for all the components of target vessel failure, cardiac death, target vessel MI, ischemia-driven target vessel revascularization, although for cardiac death and target vessel MI, the events were numerically lower in the OCT arm compared with the angio arm, but it didn't reach statistical significance. So there was a lot of discussion here why this happened. The investigators did note, and they did do a comparative analysis before and after COVID, showing that after COVID, for whatever reason, patients did not want to come to the hospitals for revascularization and stayed with optimal medical therapy. Nonetheless, I think the message here is imaging, intracoronary imaging, does reduce something very clinically relevant, but perhaps not statistically relevant, like cardiac death and target vessel MI. And, again, another clinically relevant item is the stent thrombosis. But other imaging trials were actually very strongly positive. One was the October trial. So the premise for the October trial was that we do know from the eUltiMaster registry and the Syntax trial that bifurcations have higher mortalities and have higher major adverse events. So the October trial was designed to look at bifurcations and complex lesions specifically, and looking at clinical outcomes compared with standard practice where the PCI was done with angiography guidance alone. The primary endpoint was major adverse cardiovascular events, which was a composite of cardiac death, target lesion, myocardial infarction, and ischemia-driven TLR at 2 years. And the secondary endpoints were all-cause mortality, cardiac death, the individual components. They ended up enrolling over 1,200 patients from 38 different centers in Europe, 600 to the OCT arm and 600 in the angioadone arm. And at 2 years, the major adverse cardiovascular events in the OCT was 10.1% and angio was 14.1%, with a relative risk reduction of 30%. So differences in the secondary clinical endpoints were numerically lower for all endpoints, but they didn't reach statistical significance with OCT. So really, there was no apparent difference in the procedural safety. The volume of contrast and procedure time were slightly increased with the OCT arm compared with the angio, but it really didn't make a difference. So overall, the conclusion here is that for complex PCIs and bifurcations, OCT did reduce hard endpoints and major adverse cardiovascular events. These two trials compared OCT to angio alone. Now, there was another interesting trial that came from South Korea, and this looked at, it was an investigator-initiated prospective trial, pragmatic design that really wanted to look at IVUS compared with OCT. They took 2,008 patients, randomized them 1-to-1 to OCT-guided or IVUS-guided. And the average age of the participants was about 64. Women were only 21%. Overall, 33% were diabetic. The majority were actually chronic coronary syndrome, 76% compared with 23% in the ACS arm. And the primary endpoint, again, was a composite of death from cardiac causes, target vessel MI, ischemia-driven TVR at 1 year, powered for non-inferiority. And here, they were comparable. So the primary endpoint occurred in 2.5% of those who underwent PCI guided by OCT and 3.1% of those who underwent PCI guided by IVUS. And regarding the safety endpoints, the incidence of contrast-induced nephropathy was similar in both groups, 1.4 versus 1.5 respectively. So patients undergoing PCI with OCT was non-inferior to IVUS when it comes to death from cardiac cause, target vessel MI, or ischemia-driven target vessel revascularization at 12 months after the index procedure. So that was reassuring. But then, as you mentioned, the meta-analysis, it was a network meta-analysis that was presented by Greg Stone, and it really helped bring the whole field of intracoronary imaging into perspective. So what they did here is that they analyzed the overall impact of intravascular imaging, be it with IVUS or OCT, in improving outcomes compared with angiography alone. They looked at IVUS versus angiography, OCT versus angiography, and then IVUS versus OCT. They selected 20 randomized trials and included over 12,000 patients, about 12,428 to be specific, who had both chronic coronary syndrome and acute coronary syndrome. They ended up with 7,000 plus patients allocated to the intravascular imaging group and 5,390 in the angio-guided group alone. And then they followed them up and saw 6 months and 5-year outcomes in these patients. So in terms of intravascular imaging compared with angiography, the results were consistent, where the primary composite outcome of target lesion failure was by 31% compared with angiography, was lower in the imaging guidance compared with angiography. And when it comes to the secondary outcomes, intravascular guided PCI resulted in reductions in cardiac death by 46%, target vessel MI by 20%, TVR by 29%. So there's and stent thrombosis by 52% compared with angiography guidance. And then when they looked at OCT guided and IVUS guided compared individually against angiography and each other, the analysis did not actually at that time include the Octavus. It was done before the Octavus. Interestingly, Davide Capodanno did a commentary where he actually plugged in the Octavus and again did not find any comparative difference. So when you looked at any imaging or IVUS alone or OCT alone compared with angiography, they fared much better in terms of hard endpoints. And when you looked at IVUS versus OCT, there really was no difference even when they plugged in the Octavus trial. So really, and the results have been very consistent when you look at all modalities. So really, this network analysis was very important because putting it in perspective, most certainly there is a reduction in major adverse cardiovascular events, including cardiac death, when any form of imaging is noted. What I take from that is that get familiar with an imaging modality. So if you're good at IVUS, a good IVUS is better than a bad OCT. If you're good at OCT, a good OCT is better than an IVUS. And interestingly, the acute coronary syndrome guidelines were elaborated during ESC 2023. And they actually did comment on intracoronary imaging, where for patients who had an identifiable culprit, the recommendation that they gave was 2A, to use any form of imaging, IVUS or OCT. But in those in whom the culprit was ambiguous, they recommended, they preferred OCT in the guidelines, and they assigned it a class 2B recommendation. So I think perhaps the guidelines may eventually change as well based on the October trial, where at least for complex and bifurcations, they are going to make a stronger recommendation to use intracoronary imaging. So interestingly, how much imaging do you use, Ankur?
Yeah, so, I was going to say thank you for, again, eloquently describing those, complex studies and trials. And I was, really interested to read the meta-analyses, and, reason why I even brought this up, because, our group had done a similar meta-analysis looking at 14 randomized clinical trials and comparing IVUS or OCT with angiography. So IVUS versus angiography and OCT versus angiography, and IVUS versus OCT, in relation to angiography. It was a network meta-analysis, which was, actually published last year in SCAI, and showed very similar results, compared with some of the individual level meta-analyses, which was published during the meeting. Now, granted, ours was a study level and not an individual patient level, but I was just extremely fascinated to see that the conclusions that were drawn from both these networks were actually absolutely congruent and very similar. Because the study which we had published last year showed that the odds of major adverse cardiac events or cardiovascular mortality or even TVR were similar between the two imaging modalities, but were significantly lower if compared with angiography alone. To answer your question, Mirvat, I'm an IVUS user, and I've over the years graduated to using intracoronary imaging in upwards of 75% of my PCIs. So I'm very comfortable with it. If there is even an iota of doubt with regard to stent apposition, I'm very quick to using IVUS. I use it in elective PCI cases involving proximal vessels, because that's where you may size them differently. I certainly use them in acute coronary syndromes, particularly with RCAs, because RCAs can they can fool you and trick you. In my own experience, so I find IVUS always very telling to me each time I use it in the setting of an acute coronary syndrome involving the RCA. Without a doubt, I use both physiology as well as imaging when I have to make a determination of the severity of left main disease, because that obviously has important implications for the patient. Or, in case of left main stenting, again, looking at the polygon of confluence, as they call it, the 5, 6, 7, 8 rule, IVUS is so crucial. You certainly brought up that study which looked at the superiority of imaging in bifurcation cases. So that is the typical pattern of my practice. How about yours? How do you use imaging in your practice?
So I started with IVUS, and I'm picking up OCT more lately, and I think the more I'm using OCT, it's just clearer. The only thing is you need, contrast and so on. And IVUS just seems like in the middle of the night, and any other time, just a very plug and play kind of device. So honestly, like you, the more you use it, the more you appreciate what you learn when you're looking at an artery well beyond what your naked eye sees on angiography. And it really does help with decision making. We have a huge population of diabetes. And so a lot of them have diffuse vessels, and it's vessel disease, and it's very difficult to identify landing zones and so on. So a lot of the times the imaging does help us at least find something reasonable. And, a vessel may look very thready and small, but when you do the IVUS or the imaging, you appreciate that it's actually a bigger LED or a bigger RCA than you imagine. So, yeah, absolutely. I think there's more to see with the imaging.
Yes, I agree with you. I think also one more comment I'd like to make here, that you brought up specific use of imaging in my practice. And, the one other place where I absolutely would use it is, to ascertain causes of stent failure. So, patients with in-stent restenosis, whether that in-stent restenosis occurred because of new atherosclerosis or stent malapposition or undersizing, or if there was a stent fracture, if there was a distal edge dissection. You can't come up with these diagnoses, and you can't come up with the etiology if you don't image. Would you agree?
Oh, yes, I agree with you completely. And, sometimes when you're struggling to understand why you don't have such great flow, it eliminates the guesswork. Is it no reflow? Is there a flap, a dissection flap that's really, impacting flow? So you put the catheter in there, and it just helps you see more and helps you decide what your next step is, really. So thank you for bringing that up. Absolutely.
Yeah, I think I completely agree with you. Particularly in even in the scenarios of, like you mentioned, acute vessel closure, which happens not infrequently in acute coronary syndromes, particularly with large thrombotic burden. It just helps you to ascertain whether you appropriately covered the lesion, whether there was intramural hematoma or distal vessel dissection or dissection following PTCA. I mean, it just gives you a plethora of information you would otherwise miss, and like you said, just eliminates the guesswork, which is very relieving, in the setting of an acute coronary syndrome and an unstable patient on the table. Mirvat, this has been such a great, discussion with you as always is, and thank you for coming back to discuss these important trials with us on Parallax. A little tangential topic here. How was being in Amsterdam with all the colleagues? I mean, I just was following your Twitter/X feed and also your LinkedIn feed, and you just seemed busy. You were, up and out and about, and meeting and collaborating as you usually do. How was it to be there?
Amsterdam, the weather was just very pleasant, and it's just a really nice city. Unfortunately, we got very busy at the meeting, and it was just so wonderful to see everybody and just do the networking again with colleagues, discuss and debate these trials and what we think of them and how they'll impact guidelines and practice. So it really was nice. But the other thing that's nice about these general meetings, general cardiology meetings, is that you get to network with colleagues outside your specialty. So the imagers and the heart failure specialists and so on, and you end up feeling more of a better, well-rounded clinician and not just, a cath lab junkie. And that's what I enjoy about it.
Yeah, no, thanks for bringing that up, which, I know that the focus of this conversation here today was the interventional trials, with regard to all the data which were presented. But any particular trial from heart failure that stood out for you, or from imaging actually that stood out for you at ESC?
Again, I mean, the guidelines, there are new guidelines on cardiomyopathy that came out, which were very interesting. They did upgrade the use of cardiac MRI, which is going to be interesting in how we end up, delivering that in real practice, because there are not as many MRI specialists and not as many machines available for that. But the other one was the STEP HF, which was also very good. And, it looked at patients who have heart failure, but don't necessarily have to have an event. And those patients qualify for treatment, irrespective of their hemoglobin A1C, or in other words, diabetes control, and irrespective of their ejection fraction. So I really like that trial as well. And I do think that will be very impactful on practice.
Absolutely. Well, Mirvat, thanks again for being with us, and thank you for all your knowledge and wisdom, and sharing pearls of clinical practice with our listenership. Any closing remarks for Parallax? You're actually at the helm of the 100th episode, like I said, and we'll be broadcasting this soon, and then you'll be followed by Professor Valentin Fuster. What do you have to say about that?
Really excited to hear the 100th episode of Parallax. And again, Ankur, congratulations. You've really taken the whole spectrum of cardiology and you encapsulate it, and the conversations are light and meaningful. And, we can access them anytime, when we're driving in our cars, when we're sitting in the cath lab waiting for our patients to be loaded. And just, I really congratulate you. You've filled in a gap, an important need for us as cardiologists, and very exciting work that you're doing. So please keep doing the good work that you do.
Oh, no, thank you. That certainly means a lot to me from a colleague like yourself. And, thanks again for your time. And I wish to see you around, hopefully soon at either TCT or AHA. I'm sure you'll be here, or I hope that you'll be here.
Well, hoping. Fingers crossed. Thank you, Ankur.
Thank you.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.